Good afternoon, ladies and gentlemen. I'm Adrian Backus, FIN Director for Partnerships and Community Outreach. I'm pleased to introduce Thomas A. Farrington, founder and president of the Prostate Health Education Network and a 21-year prostate cancer survivor.
And welcome to FIN's 17th annual African American Prostate Cancer Disparity Summit. We're pleased to be with you today as we bring in the summit, and we also celebrate Prostate Cancer Awareness Month. I want to extend a special thank you to our audience for joining us today. We want to acknowledge and thank our sponsors for their support. Their support is making this program available to you today. This is our 17th year. 17 years is built on a foundation that was developed during 15 in-person summits that we hosted in Washington, D.C., beginning in 2005. And I have to recognize my wife, Juarez, who managed those summits during that 15-year period. So, Juarez, thank you for all your support and establishing our summit foundation. Our 2021 virtual summit will consist of 4 weekly sessions held on each Wednesday of September beginning at 1 p.m. Eastern Time. We will focus on a broad range of issues in addressing the prostate cancer racial disparity during these sessions. Session 1 today, the impact of COVID-19 on the prostate cancer racial disparity, examine how COVID-19 is transforming prostate cancer care as a catalyst and expanding the use of telemedicine. Session 2, effective community awareness, outreach, and engagement strategies highlights efforts to raise public awareness and engage communities in efforts to eliminate the disparity. Our session 3, enhancing early detection, treatments, and clinical trials education, focuses on innovative approaches to educating the public and patients. And we end with session 4, social determinants of health, financial toxicity, and policy initiatives, addresses the multi-dimensional aspect of the fight to eliminate the prostate cancer racial disparity. We truly hope that these sessions will provide you with a better understanding of the challenges and efforts that are required to eliminate the African American prostate cancer disparity, where Black men die at a rate more than twice that for all other men. I will introduce one of our champions now. As we enter again our 17th year, you must have champions to support your efforts. And the Congressional Black Caucus has supported FIN's efforts since 2005, with our very first summit. Congressman Gregory Meeks out of New York is our sponsor for our participation in the Congressional Black Caucus Annual Legislative Conference. He is a true friend and committed to the fight against prostate cancer. I'm going to bring Congressman Meeks on to make a few remarks, but I'm going to introduce Dr. Mitchell now. And after you hear from Congressman Meeks, the next voice that you will hear will be that of Dr. Edith Mitchell. Dr. Mitchell is a national leader in healthcare. She is a committed friend and supporter of FIN's efforts. She is a clinical professor of medicine and medical oncology at the Department of Medical Oncology and the director of the Center to Eliminate Cancer Disparities, associate director of diversity affairs with the Sidney Kimmel Cancer Center at Thomas Jefferson University in Philadelphia, Pennsylvania. Dr. Mitchell is also a member of the President's Cancer Panel. And in addition, Dr. Mitchell is a retired Air Force general. So now you will hear from Congressman Gregory Meeks, and then you will hear from our moderator, Dr. Edith Mitchell. Thank you.
Hello, I'm Congressman Gregory Meeks, and it is my pleasure to join you again for the 17th annual Prostate Cancer Disparity Summit hosted by the Prostate Health Education Network. And let me first thank my friend and the founder of FIN for inviting me again to speak for the 17th time at this health workshop. And it's important, especially given the mission of this summit and what it means, particularly for Black men in America. Prostate cancer continues to be a silent killer in our community. And FIN's mission to increase support and resources toward the war against this disease, with all of its racial disparities, is still as important and as critical as it was 17 years ago. In fact, for the past 20 months or so, COVID-19 has been on top of all of our minds. But unfortunately, our collective focus on defeating COVID has made it even more difficult for advocates like yourself in this ongoing fight against prostate cancer. Some cancer screenings saw a 90% drop at the beginning of the pandemic. And although cancer screenings have increased significantly since the start of the pandemic, racial disparities in cancer testing consistently remind us of what we are up against to ensure more equity in healthcare. And that's why in this fight, this is what we must continue to do, to educate through summits like this one. But I also think creatively about the future and how to best reach underserved communities. So I'm glad that on today's agenda, there is a discussion on telemedicine and how leveraging new technologies can help in addressing racial disparities in prostate cancer testing. As always, Mr. Farrington and FIN continues to bring relevant discussions to policymakers that really move the needle here in Washington, D.C. Last, let me also acknowledge my dear friend, the late Congressman Alcee Hastings, who lost his life to the silent killer in the Black community, pancreatic cancer. Our fight against various forms of cancer remains for me as we continue to lose family and friends at disproportionate rate due to inequities in healthcare, which are inequalities that can be fixed through the law and leveled through better access. Let me also thank Mrs. Farrington for her work in making sure that this summit is always on time and important. So I look forward to hearing more about FIN survey results and further engaging with all of you as we think through the future in our efforts against prostate cancer and other forms of cancer that our community is up against. I hope that next year we'll be able to meet again in person, for we cannot stop this fight until we make sure that all men are being tested so that we can defeat this disease of prostate cancer. And we can do it by getting tested early. So thank you, and I hope to see you all in person next year. Have a great summit.
Thank you so much, Mr. Farrington, for inviting me again to speak at the Prostate Health Education Network. It is always a pleasure to speak, and especially when we are associated with the Congressional Black Caucus, and we have the joint efforts to work together in collaboration against the deathly prostate cancer in the African-American population. So thank you, Mr. Farrington, for inviting me again to be a part of this effort. And thanks to our audience for being here with us. Thank our speakers that we have with us this afternoon. It has been 50 years since 1971 when the Congress approved the National Cancer Act, And the act was signed by then former President Richard Nixon. This year of 2021 marks 50 years of the National Cancer Act. And this National Cancer Act established our cancer centers throughout the country, which there are now 72. And these cancer centers have led the effort in organizing some of the important research that has made a difference in cancer survival in this country. It is also important to know that not only the cancer centers throughout the country, which my own institution, Thomas Jefferson University, is one of the NCI designated cancer centers, but it established the National Cancer Centers, the cooperative groups, the lead academic sites throughout the country, the NCTN, and others with research on cancers in this country. And this has led to more than a 30% decrease in cancer death rates in this country. So welcome to our discussions on prostate cancer today. It is well recognized, as reported by the American Cancer Society earlier this year, that in the year 2021, we expect approximately 1.9 million individuals in the United States to develop and be diagnosed with cancer. Unfortunately, we also expect somewhere approximately 608,000 individuals to unfortunately lose their lives to cancer. And for prostate cancer, we expect 248,000 individuals to be diagnosed with prostate cancer. And again, unfortunately, 34,000 individuals will lose their lives to prostate cancer this year. We also recognize that African Americans suffer disproportionately in both the incidence rate as well as the mortality or death rate from prostate cancer. With African Americans having higher rates of prostate cancer, developing prostate cancer at a younger age, and having more aggressive cancers leading to early complications and earlier death rates. And thanks to FEN, we have produced lots of information, encouraged in participation in clinical trials, and therefore continuously lead the way to getting this information out to our community, and consequently more individuals taking advantage of all of the leading work and the research that has been done in prostate cancer. I'd like to introduce you to our first speaker today. Dr. Daniela Whitman is a clinical professor at the University of Michigan. She is a clinical associate professor. She is also the associate editor of the Journal of Sexual Medicine. She is a psychotherapist and a researcher in prostate cancer and in patients either undergoing treatment or who have undergone treatment in prostate cancer. At this time, I would like to introduce to you Dr. Daniela Whitman. Dr. Whitman.
Hello, everybody. I'm having trouble starting my video. It says you can't start your video because your host has stopped it. So I have to ask to start it. Thank you. Thank you very much, Dr. Mitchell, for introducing me. Thank you, Mr. Farrington and Dr. Crawford, for having invited me to present to you today. I feel very honored to have been invited. And here we go. First, I want to say that I have no financial disclosures, and I want to acknowledge Dr. Ellie Moodle, who is the University of Michigan's telemedicine expert, and Dr. Anthony, who's an expert on trust and healthcare, who have contributed to my presentation today. So Dr. Mitchell already spoke about health disparities in prostate cancer, and I want to add just a little bit to that same context before I start speaking about telemedicine. I think that we all are aware, and the audience more than anybody, about the fact that it is very difficult sometimes for African Americans to trust our healthcare system because of abuse in research and in medicine, and to this day, because of discrimination in care provision. A couple of recent studies to just mention. We know that prostate cancer specific mortality is higher among African American men compared to white men, and that even as recently as 2015, patients treated for prostate and bladder cancer, Black race was associated with lower odds of treatment at high volume centers, which means centers where people have the highest level of expertise in providing that treatment. So that's just as a context. I want to speak also to the availability of insurance before I start speaking about telemedicine. So often it has been spoken about as sort of an important factor, which is genetics, that might distinguish African-American men from white men in terms of outcomes. And I think we are learning now that it may just be that access to resources and access to care may be a more important factor. In a study done in Massachusetts of almost 21,000 men with prostate cancer, it was found that Black men had a 17% lower cancer-specific mortality than white men. And this is because Massachusetts has a much more general access to insurance than many other states in the United States. Similarly, in a population of men who were and women who were reaching age 65, there was a study that tried to look at what difference access to Medicare insurance would make to health disparities. What was found in this study was that the ability to have Medicare insurance led to 53% reduction in health disparity between white and Black individuals. So again, I think we are learning that access to resources is a huge reducer in health disparities, and let's keep that in mind when we speak about telehealth. So can telehealth contribute to reducing health disparities? First, let's talk about what telehealth is. We think of it as using remote technology to manage healthcare. That means to diagnose, treat, and then manage and follow up. Different words, different language is used to describe telehealth. Sometimes people talk about virtual care. Sometimes they say telehealth, telemedicine, and digital health. It's all the same thing. There are different kinds of telehealth or telemedicine. A person could be having a FaceTime or Zoom call with a healthcare provider. They could be talking on the phone. They could be emailing with a healthcare provider or using an app that helps them, application that helps them manage their healthcare. All of these and others can be considered telemedicine. So what have you learned from the COVID-19 pandemic and telehealth? Telehealth was originally intended to help people who lived in remote locations to access telehealth, which otherwise would have cost them time away from work, gasoline for their cars, possibly even a hotel so that they could go to health centers, health providers that were at very remote locations from them. So the idea of providing telemedicine was to reduce the disparity in access. And originally, the way it was organized was to have patients be in health facilities like a clinic and have a video call or a phone call with a healthcare provider who could be hundreds of miles away. This was pioneered very much by the VA system, and I remember in the 20 years ago they were doing video visits with patients in northern Michigan, which was hundreds of miles away from Ann Arbor, which is where the VA hospital was. But the COVID-19 pandemic changed everything. It removed a lot of the kind of regulations that governed telemedicine, so patients then could connect from home to their healthcare providers, and providers were allowed to practice across state lines. Telehealth visits, whether they were phone calls or video visits, were reimbursed at the same rate, and patients could have their co-payments waived, and even privacy rules were relaxed so that, for example, I have done a lot of telemedicines with my sexual health patients, and we can use phones, we could use FaceTime, we could use Zoom. Some of the regulations about privacy are coming back in, but sort of the final way how this is all going to be regulated, are not quite in yet, because we are still adjusting to the system and trying to figure out how much telemedicine will stay. I have a figure here from a study that was done by the biggest insurer in Michigan, Blue Cross Blue Shield, of their patient visits over time. So on the bottom line here, you see the timeline, and on the left here, you see weekly ambulatory or outpatient care visits. And you can see with the thick line, black line, that these are all the visits that occurred. And then the broken lines at the top here are the in-person visits, while the ones on the bottom are the telehealth visits. And you can see that early during the pandemic, telehealth visits increased, and they decreased, but they really never went down to zero. You can see that before the pandemic, there were hardly any telehealth visits. We were doing them, but very, very little. So it looks like these telehealth visits are here to stay. And I think that there has to be a better understanding how they can contribute positively to managing healthcare, and how they can reduce disparities for all kinds of populations, but can they also contribute to racial disparities as well. So let's see what the role is likely to be. There are things to consider. It's a complicated relationship, healthcare and telehealth. First of all, is this going to be affordable, both patients and for healthcare providers? Will insurance cover all telehealth visits? Is it going to be accessible, because people need devices that enable them to access healthcare, and they need broadband, and not everybody has that at this point. And is that a methodology that will be acceptable both to healthcare providers and to patients? So those are the structural issues, but then there are also individual issues, personal issues that could influence what factors will positively associate telehealth and reduction of disparities. A study was done at the University of Michigan last year between April and June, in which they tried to look at some of these factors. So they tried to look at telephone use versus video use, and they found that the older the patient, the more likely they were to use the telephone rather than video visits. The video visits are in yellow, telephone in blue. I would say I see that to some degree in my own sessions as well. And if you think that prostate cancer patients, men with prostate cancer, are on average 65, this is where they fall in this graphic. So some work will have to be done to make sure that people, A, have the devices, B, have broadband, and that they also know how to comfortably use those devices. Then the issue of geographic location. You remember I was saying that when people live far away from health centers, they need help via telemedicine to access specialty healthcare. Well, in the same study, they found out that in Washtenaw County, which is down here, which is where University of Michigan is and another very big healthcare system is, they were the ones who were the biggest users of telemedicine as compared to Antrim County in northern Michigan, which was amongst the lower users. And you can already imagine what would be involved: likelihood of older population, no broadband or very poor broadband, and possibly sort of insufficient ownership of devices. And here are the individual characteristics that were found to be associated with not using video visit. One was older age, which we already discussed. Another one was African-American race, the need to have an interpreter, being on Medicaid, and low broadband access. So you can already see some of the areas that are going to have to be addressed for telehealth to be a useful methodology for providing healthcare. So the question of reducing health disparities through telehealth is complicated. I think we are sort of seeing that. This figure, which is not very clear, I hope you can see it well enough, is from a study that was conducted last year to look at how urologic conditions could be managed through telehealth. So in blue, you see in-person clinic visits, and in yellow, you see video visits. And there are two aspects of urologic care that are relevant to prostate cancer: andrology and oncology. So what we have found in oncology is that, with the exception of the surgery itself for prostate cancer, MRIs and biopsies, and blood tests, most of the clinic visits could be done in video form. Even consultations to make decisions about treatment, certainly follow-up, and our survivorship clinics have been done pretty much all in video format. And then andrology is the area of urology that addresses sexual medicine. So for men who were having problems with erectile dysfunction after surgery for prostate cancer, as you can see, the yellow bar is higher than the blue bar. Addressing sexual problems can be done over video very, very easily. So clearly, telemedicine can be very helpful in the management of prostate cancer. And for some people who have to come a long distance, for example, this could be very positive. There are also programs that have been developed and that people can use. We have developed with other universities in the United States an online program for the management of sexual issues after prostate cancer. It's a sexual recovery online program that is available from our cancer center. Anybody in this audience can actually access it as well. And there's a similar program in existence in Canada as well, although that one is championed by nurses. Ours is completely online. So there are clearly possibilities for introducing telemedicine into prostate cancer care. I think what needs to be understood is, however, some of the structural issues about resources, but also preferences, people's preferences. So some time ago, and it's now probably 15 years ago, there was a study of support groups of cancer patients that were attended by African Americans. And what they found, and this may be different now, so I'm not assuming it's the same, but it has to be understood. African Americans in these groups reported that they were using the internet for information, not so much for emotional support as compared to their white counterparts. They sought instead emotional support from informal sources such as family, friends, and church. So you can also think of those sources as trusted sources. And African Americans preferred to be in a group tailored to their needs. In other words, they really wanted to be in a group with other African Americans because they felt that it would be much more responsive to have that kind of a group. When asked about whether they trusted information provided either by the internet or in the support group, African Americans were less trusting than whites. So I think in conclusion, the takeaway here is that telehealth, like all healthcare, is resource and potentially culture driven. It's important for people to be able to have broadband. They have to have the devices and know how to use them. They have to be confident that insurance will pay for telehealth visits. And they have to feel that it's a medium that can be trusted. Thank you. I'd be happy to take any questions if that's appropriate, or just wait for the panel.
So Dr. Whitman, thank you so much for that great presentation. We really appreciate that. And we have some time now for a few questions from you or for you. And I will start by asking you, what do you do about those patients who don't have access to telemedicine? Either they're in rural areas without a tower, or their devices are not suitable or have been updated for telemedicine. How do you communicate with those patients as well so that we see nobody is left out?
I think those patients, on the whole, we have to work with local healthcare providers to find whether we can get rides for those people and bring them to in-person visits. Because I think it's so important, especially in cancer work, to establish relationships with people, and we cannot shortchange them in any way. And so that is probably the only way. Sometimes the American Cancer Society can be very helpful in providing transportation. That, of course, is complicated by COVID. But that is one of the services that local American Cancer Society can provide, volunteers who bring people to appointments.
Yes, that is true. And also what I've been able to do in my office is the staff goes through each telemedicine, and prior to the patient's telemedicine visit, they will let me know what the patient's access resources are. And they will send me a message in using telephone for those patients. I'm able to, one, maintain communications and see what other resources are needed, and therefore can intersect with the local authorities. But probably more importantly, the patients like that and really appreciates my telephone call from them to find out what their needs are. And then we can provide prescriptions, working with the local pharmacies to make sure that those patients, despite the pandemic, are not left out. So that's one of the things that we do. So I think there are a few questions from the audience. And Mr. George, if you can bring up the questions from the audience, please. Okay, I see that the questions, I think we have answered this, but what can be done to address the barriers to broadband? And Dr. Whitman, if you want to summarize
Sure.
that again, the barriers.
I mean, I think the
patients.
barrier, honestly, the barrier to broadband, that is a political, financial solution. You know, that towns, counties, states, the country, there has to be a recognition that broadband is essential to so many things, including healthcare. You know, and no individual can provide broadband for themselves unless they move to somewhere where there's really good access. And so I think that this is a broader issue that goes beyond healthcare, but definitely also influences healthcare.
Absolutely. And the next question from the audience, is there a difference in satisfaction by a video visit versus a telephone visit?
So I would say that, so I don't have any data to prove this. I only have clinical experience. I think that there's no doubt that people feel, on the whole, people feel happier when they can see their provider. And when there can be a little bit of an exchange that seems more personal than on the phone. On the other hand, I have some people that I see, and perhaps it's because it's for sexual concerns, they have perfectly good access to broadband, but they prefer phone calls. And I think it's a kind of a privacy issue. They don't feel comfortable using video visits to discuss such private issues as sexual health. So I think it varies. I think overall, most people would probably say they prefer video visits, but in some circumstances, the telephone is preferred.
Yes. And our next question is, how has COVID accelerated the telemedicine movement?
Oh my goodness, hugely, hugely. I can tell you from our experience at the University of Michigan, in March, we went to telemedicine wholesale. You know, we canceled surgeries, we moved everything to telehealth. The system was not ready for it, so we were constantly crashing the system. So upscaling the ability to provide telehealth visits, that was a very big challenge. But we actually moved all our outpatient visits that didn't require a physical procedure or physical exam to telehealth. And so it was hugely influential because all of a sudden, everything that was happening in person was no longer happening in person. It was happening via video and via telephone.
Yes, and we actually found the same thing at Jefferson, that our outpatient visits were severely curtailed, and the focus on caring for the inpatients who were unfortunately suffering from COVID. And we also wanted to make sure that patients were safe and we could social distance in our waiting rooms. So we really did not want a lot of patients in the waiting room. And therefore we had to use the staff to help us devise methods of taking care of our patients, giving those patients who needed treatment access to that treatment, and making sure that others who did not need treatments in the center to be cared for, to make sure that medications were given appropriately. Our outpatient pharmacy helped with that in making sure that medications were delivered on time and appropriately to those patients. So we really had to devise a totally different set of strategies in reaching patients and making sure that they receive the appropriate treatments.
Yes. And Dr.
So-
Mitchell, sorry.
Yes, go ahead.
I think that you mentioned the fact that there was a kind of decrease in screening during COVID, that there was sort of a, for some patients, I mean, when you asked about how COVID influenced care and what happened with telehealth, there was only so much that telehealth could do. And because surgeries were postponed and people did not come for screening, care was also delayed for many patients, which caused a lot of distress to both patients and their healthcare providers. Fortunately, in many cases, prostate cancer was the kind of cancer that could be delayed for many people. And their outcomes were not likely to be affected. But people are very worried about that. And, you know, there could be people in this audience who went through that experience. So it was a very challenging, continues to be a very challenging time.
Certainly. And what I can say is that the National Cancer Institute is actually collecting data on patients with cancer during the pandemic. And as a member of the President's Cancer Panel, we are actually strategizing for the future so that we're using this information gained through the pandemic and what we've learned to plan for the future so that we have good plans so that in case there are other entities in the future, such as other pandemics or other circumstances, that we can adapt very easily. For this pandemic, we had no experience in the medical community in what to do. So we had to devise strategies as the pandemic progressed. So we are continuously learning. I'd like to thank you, Dr. Whitman, for your exceptional presentation today and your contributions to the Prostate Health Education Network. And thank you so much. And we will now, Mr. George, Jerry, we'll go on now to our next speaker.
Thank you very much, Dr. Mitchell.
Our next speaker, and I am so proud to present, is Dr. Keith Crawford. Dr. Crawford has an extremely long and excellent service, both in clinical medicine and in laboratory research. He is now Director of Patient Education, Clinical Trials, and Medical Education at the Prostate Health Education Network. So at this time, it is my pleasure to introduce to our audience, Dr. Keith Crawford. Dr. Crawford.
Good afternoon, everyone. Let's see. Good afternoon, everyone. And thank you for the introduction, Dr. Mitchell. And thank you for laying out the groundwork, Dr. Whitman. I'm going to share my slides with you. And I'm going to be going over a survey that Finn conducted. One thing I want to say, this information came from the Finn Members Network. And this is important, is because when Finn has a reach nationally, and it's not just from since our home is in Boston, but it's not just restricted to the Massachusetts area. So we have coverage throughout the nation as well as in parts of the Caribbean. But what we do want everyone to recognize, when we pull information, we're getting information from our target cities and target states that represent in excess of 90% of the Black population in the United States. So I wanted to bring this up because our member network serves as an excellent resource so people can hear the voices of Black prostate cancer patients. And lastly, I just wanted to take the opportunity to also thank our prostate cancer survivor network members, because without their support, we would not have been able to carry on these survey. And the survey was extremely timely. Now, there was one other point. Again, I wanted to thank Dr. Whitman, and she brought out some key points that I want to highlight before I go on with the survey. And she said, one, African-American men or African-Americans are looking for a reliable source of information. And as looking for a reliable source of information, as it relates to telemedicine, they're not as likely to want to participate in telemedicine. And the third point is that Dr. Whitman demonstrated from her information, her presentation, that prostate cancer can be managed by telemedicine. So our survey begins with trying to understand, did telemedicine care, did a patient receive telemedicine care during COVID-19? And when we look at our respondents, which were 128 at the time, 65% of those said yes. Our next question, were you satisfied with your telemedicine care? And again, those that did receive telemedicine care or use telemedicine, 76% of those were satisfied with their care. The next question that we wanted to know is whether or not you were negatively impacted due to the delay in care during COVID. And this was a nice, bright, shining finding when we start talking about, in the midst of COVID, that 85% of those that responded that did use telemedicine told us that they were not negatively impacted. Now, our last question focused on what the network members, what did people believe? Now, did they believe telemedicine will increase the disparity due to lack of access during understanding by certain patients? And what we saw here was 39% of the respondents, 39% felt that it would increase the disparity that existed. Where in contrast, telemedicine care would eliminate the disparity was believed by 28% of the population. But I wanted to highlight one area, and one area is there was a third of the population of the respondents that clearly said that they were undecided and needed more information. So I highlight that, put a star by that. Next slide, and our last slide in our survey is our takeaways. Now, recognizing that we had a high rate of experiencing telemedicine care, 65%. And of that population, 76% of those, over 3/4 of that population, were satisfied. But even with the high levels of satisfaction, the largest number of respondents, 38%, believed that telemedicine would increase the disparity. Greater than a third felt that telemedicine would increase the disparity. And only in contrast, only 28% of the respondents believed that telemedicine would eliminate the disparity, while the remainder, 33%, were undecided. So the reason why I highlighted that, this last 33%, because what we do know is from consistently where it was screening, treatment options, or a clinical trial, patient education is needed. And patient education is needed for telemedicine. And we feel that it will make a major impact in eliminating racial disparity. Thank you. That's the end of my survey. Are there
Thank you so much, Dr. Crawford. And I'd like to start the questions for you. And that is, number one, how many individuals answered the survey and contributed information that you have so beautifully summarized and discussed? How many patients or how many individuals returned answers to the survey?
So in the survey, we had a total of 128 responses that came from PHIN's network members.
Mm-hmm. Okay.
And consistently, this is a statistically relevant population. And this population, and again, I'll highlight it, it was not just restricted to the Northeast, but it was throughout the country. So you got a feel for whether it's urban, suburban, north and south.
Okay, thank you. Thank you. We have been here, Dr. Matthew Kennard. And Dr. Kennard's question is, does Medicare coverage cover the range of health conditions, or are there selectivity of the conditions that Medicare can cover for patients?
Well, I might have to bring in Dr. Whitman for that question, to answer that question, because I think she's more actively participated in the care of patients and with telemedicine. Dr. Whitman.
Okay, I'm here.
It's from our members of the program today. Dr. Whitman.
I'm here. So we have not had any problems with coverage of really any procedures. And, I live in prostate cancer. So these are mostly men and their partners who are in their 50s and up. Of course, there are a few that are younger as well. We've had no problems with coverage either from Medicare or insurance companies. And one of the things that I'm going to put a plug in for is that Medicare covers sexual health. So sexual health visits are also covered. Telephone visits, video visits, both of them.
Yes, and that has been my experience. And in fact, there is a list of disease processes that you can go onto the Medicare website.
Mhm, yeah.
But for the most part, most medical conditions are covered. For example, if you are doing a telemedicine with a prostate cancer patient, and that patient addresses concerns that lead to, let's say, a heart exam, you can then consult a cardiologist or other specialists based on the needs. So it has really been very convenient, not only for disease-specific diagnoses, but if you encounter another problem for the patient, you can then provide a consultation to another provider regarding that problem. So it's really been very, very beneficial. Insurance companies have worked with us, and the healthcare systems have devised methodology to allow for indications for the coverage of the patient, and therefore to assist the patient. Our concern was that patients should not be billed inappropriately for telemedicine visits, and that has been addressed by not only Medicare and Medicaid, but also other providers of services, insurance companies for patients.
Right.
Okay, there are a couple more questions here. Dr. Richard Hackney wants to know, why was the survey, why did the survey have a low response rate? And what did we do about that?
Well,
And I guess the other
yeah.
part of that, there's another question, Dr. Crawford, were you satisfied with the number of respondents to the survey?
To answer the first question, the objective of the survey is to really get a feel for what people were feeling. And we have a response of Black prostate cancer survivors in our network that are found throughout the country. And what we see is people being honest. There are groups that clearly like the system, engaged in the system, but honestly, there's still some concerns about whether or not there'll be a change. And so from the standpoint, it's not satisfied. The answer to how I would answer that question is this. We basically open the door, turn the light on in the room. And Dr. Whitman from Michigan, from combining our network, everyone has said the same thing. And I'm going to highlight again what Dr. Whitman exposed or disclosed. And that was African-American men are less likely to participate when it comes to care in telemedicine. And two, prostate cancer can be cared by telemedicine. So it then becomes our responsibility to then educate the patient, just like we educated about screening and treatment options and clinical trials. Telemedicine will be another one of our agendas as we move forward in 2020. The answer to the other question about the numbers, the objective is, again, to hear from people. Some people may question whether or not it's statistically relevant, but the point there that I want to bring up is this, is that the voices from the network who are Black prostate cancer survivors are making this statement. And that tells us that there is a need to address this deficit or this disparity in, we want to use it, but we don't think it's going to change disparity. And it becomes our responsibility, Finn's responsibility, all of our responsibilities to change that perception.
Thank you so much for that answer. And I have another question, and perhaps this might go to Dr. Whitman, and I will be happy to answer as well. And the question is, has there been a recent discontinuation of coverage for audio-only patient calls? Dr. Whitman.
Yeah, I have not experienced that. I continue to do audio visits. I think there's a big worry about it. And there's also a worry that it's going to be reimbursed at a lower rate than video visits, because remember when in my presentation, I was talking about the structural issues such as, is it going to be financially feasible to do this? Because if it's not going to be well reimbursed, healthcare providers are not going to want to offer it. And so that means that it leaves a proportion of people out who don't have good devices or who don't have very good broadband. So, this is, I think, something that's going to continue to be negotiated. I mean, we're not out of COVID, number one. And number two, I think that as more research is being done on the efficacies and inefficacies of telehealth, it's going to influence insurance providers and primarily Medicare, which tends to dictate what other insurance companies do.
Yes, and we, at my institution, we have found the same, that there has not been a total lack of reimbursement for telephone-only visits. We do have to put a statement in the medical record of those circumstances, and the healthcare systems negotiate with Medicare to make sure that patients have access. And as providers, we have to be sure that we follow the guidelines. And Medicare always has guidelines, but if we follow the guidelines and make sure we incorporate the correct information into the patient visit, so that anyone looking at that record can see that healthcare was delivered and what were the important features of that particular visit. So it's making sure we document into the medical record, which we're used to doing. That it's not new for Medicare covered visits. So the answer to the question is, we do everything we can to provide the correct care so that each patient gets the right care for the right disease process and other conditions at the right time. So don't worry, we can work to get coverage for patients. The next question, Dr. Crawford, is for you. What is the next step after this survey? What comes next?
Well, what comes next is, as you recognize, and if you look at that, the programs that are available in FIN, we have several different ways that we approach it. We approach educating the population, and I go back again to Dr. Whitman. She brought up another key point. Black men are looking for a trusted resource. FIN is the trusted resource when it comes to prostate cancer in African-American men, hands down. So what do? We have a way of communicating with people by holding seminars, webcasts. So Dr. Whitman and I have already started planning about how to introduce telemedicine so they learn more about telemedicine. So we have the ability to write newsletters. So I kind of use the term Hansel and Greteling information, where you give people a little bit of information so they can really understand what is telemedicine. So we take what we've learned from the summit, and it lays out our agenda for 2022. So we have access to newsletters that we create. Tom has an excellent hand with his script. So Daddy's Boys, you may see telemedicine even in Daddy's Boys. You may have to look. You need to follow Daddy's Boys to see what's coming up next. And we always want to at least engage all prostate cancer patients with people who are knowledgeable in the field. And with you, with Dr. Whitman, in the field about prostate cancer, and getting people to understand the importance of telemedicine. And we also use a tool. Our objective is, everyone wants to force the patient into a particular scenario. So it's the patient's responsibility. It's not the patient's responsibility, it's the clinician and the patient to work together. So if we're going to treat it like we treat screening and treatments, and the patient participating in the shared decision-making process, that means that we have to bring the patient's understanding to a level where they can have a bidirectional interactional communication between the patient and the physician, and the physician and the patient. So like we're doing with our clinical trial rally, what is the expectation of the patient, and what is the expectation of the physician? So we have a lot of ground to cover. This is going to be an exciting time. So we're ready to get started.
Oh, thank you so much, Dr. Crawford. And we've got another question for you. And that question is, Dr. Mitchell mentioned the National Cancer Institute and 50 years of the National Cancer Act. Are you communicating with the cancer centers regarding clinical trials and prostate cancer?
Well, we've taken a different perspective, a different direction. What we've done, again, I mentioned before, it's about shared decision making. What is the patient's expectation, and what is the physician's expectation? So one of the products that we've launched last year, about the same time as the summit, is our clinical trial rally 2, which incorporates a learning session. So right now we have relationships with Hopkins, MSK through PCCTC, clinical trial sites in Chicago and North Carolina, Duke, Johns Hopkins, Northwestern, University of Chicago. And what our objective is to take patients, bring them together with the clinicians in the clinical trial sites and help them understand each perspective. So that is kind of a tool that we found is going to be very supportive of change, because you have to start somewhere. You have to improve the dialogue. And the more a patient understands the expectations of the physician and the physician understands the expectation of the patient, the easier or the greater the level of communication. And when the patient is at that level, they're in a position where there are no regrets about their choices. So we feel that that type of interaction and is very important, and it lays the foundation at every particular juncture that may play a role in disparity. There was a disparity in screening, disparity in treatment, disparity in clinical trials, and the potential disparity that will exist in telemedicine. But again, our motto is, knowledge is your best defense against prostate cancer.
That's a superb answer, Dr. Crawford. And each of the institutions that you mentioned are all NCI sponsored cancer
You got that, huh?
centers.
Yes,
Yes,
that's right.
yes.
I said, I just want to leave that for you a little bit.
So that we have cancer centers all over the country, a total of 72. And interestingly, in Philadelphia, we have 4 of those centers, and working together with all of the centers in unison, we've been able to work with FIN regarding clinical trials. And what I'd like to say to our participants in this program is that clinical trials are available for treatment of prostate cancer. They are appropriate. We work with other centers so that we are all working together in collaboration in taking care of patients. And disparities in cancer is one of the main efforts of the National Cancer Institute. The director of the National Cancer Institute last week just stated that disparities in cancer was one of the major efforts of the National Cancer Institute, and clinical trials, of course, being one of the main efforts. And patients can get information lots of different places. First, by the FIN website, and patients can get information. We can also, from FIN, refer to the various centers that you mentioned, but not only those centers. There are 72 designated cancer centers where we all work together. And it's really everybody being together. Then our patients, and we want the patients to know that we work together We want their trust. We want their participation. And if you find that you are uncomfortable with one site, we can get some help with making sure that the patient has comfort and trust in their healthcare. So don't hold back. What I say and tell my patients is the worst question you can have is the one you never ask.
Yeah, that's right. And I wanted to make one
So
other comment.
always,
Mhm.
go ahead.
I wanted to make one other comment. The project that we're working on with our clinical trials is our pilot project. Our objective is to expand, our motto is the tide lifts all boats. So with this project, it's a pilot work that we're doing with other groups. We'll begin to pilot, but our objective is to set the template that can go to all the 72 institutions that are out there.
Right.
So I didn't want to leave them out. We just getting started.
Yes. And not only are there 72 NCI designated cancer centers, but there is the cooperative group effort where there are cooperative groups, and they're called lead academic sites. And therefore, we have that network, and we have community physicians and community centers throughout the country so that no patient has to go a long distance. And we're trying to make cancer treatment, cancer information available to all individuals, no matter where they reside. So what I say to patients, ask the question. And once the question is asked, then we can provide specific information and where one can go for not only information, but also therapeutic interventions or treatments that are working and the newer clinical trials, so that our patients today who are in the FEN network and who know somebody in the FEN network, and even if they don't, we have processes where patients can get treatment, and much of that treatment can be in their communities. And it can be a collaboration between the cancer center and the community physicians in giving care to patients. So always, for patients, ask the question. Ask the question. That is great. So I'd like to ask Dr. Whitman and Dr. Crawford to give us some summaries of their presentations today. If you have some last minute words that you would like to say to our audience, please do so. Dr. Whitman?
Sure. So I think this has been such a very interesting discussion, and I have a takeaway point from the discussion, which is, I think we understand that telehealth can really be a bridge for many people, but we also have to understand that we have to advocate for people to have access to broadband and to devices, and that organizations such as the American Cancer Society, perhaps FEN, individual cancer centers have an obligation to provide training for people to use telehealth. That, I see it in my own appointments that sometimes it's so hard for people to figure out where the camera icon is and how to turn on the sound and so on and so forth. It's very frustrating. And I think, like with everything else, when somebody undergoes a new treatment, they have to be properly educated about what that treatment is going to be and how that's going to help them and how they're going to manage it every day. We may have to do that with telehealth as well, so that we can feel more comfortable using it. I think in terms of trust in it as a modality, I think that has to be further studied and understood. And, what are some of the reasons why people do not trust it or trust it less than having a conversation in a room? there are lots of opportunities to learning more about how to make it the tool that we want it to be. That's my summary statement. Thank you.
Thank you, Dr. Whitman, and thank you for your participation in the program today and the
Such a
great
pleasure.
information that you have given us. Thank you
Thank you.
so much. Dr. Crawford, how about your summary statement?
Well, Dr. Whitman has kind of addressed it all. I just like to close out that one 21-year organization founded by Thomas Farrington, a survivor. And to me, that's important. That's your trusted resource. And the thing that I'd like to close with is knowledge is your best defense against prostate cancer. And you will get the knowledge from Finn. That's it.
Thank you so much for all the work that you do, Dr. Crawford. Thank you for your presentation today. And thank you for being with us. And we look forward to further work with you through the National Cancer Institute institutions and especially
Can't wait.
our National Cancer Network. So I will make sure that you get that invitation to our next meeting. And thank you. So at this time, I would like to move to our next area of the program today, and that is with our panel. Dr. Coleman was first on the panel, and I understand she is having some network connection problems, and we are therefore moving on, and hopefully we can get back to Dr. Coleman. But our next speaker is Dr. Waterhouse, who I believe is on. And Dr. Waterhouse, if you could join us now, Dr. Robert Waterhouse, you will be the first panelist. And what we will ask you to do is give some words about area of expertise that you're working today. And your discussion topic, I believe, is will increased telemedicine impact the prostate cancer racial disparity? So at this time, I would like to introduce to the group Dr. Waterhouse. Please go ahead.
Great, thank you. And I thank Tom and Dr. Mitchell and Dr. Crawford all for allowing me to have an opportunity to speak to you about this very important topic. And it is of note that I've had the opportunity to speak with Finn forums previously and to work with the national network with direct outreach to churches on behalf of Finn. And the work that Finn is accomplishing is truly remarkable. So I thank Tom for all the work that he does, all the work that he leads. And I thank him again for this opportunity. When it comes to telehealth, from my perspective, it raises probably more questions than it answers. And just as an anecdote, as an example, I want to share real example of a type of telehealth visit. And this was not intended to be a telehealth visit. This was actually pre-COVID, where a patient, Black patient, elevated PSA, underwent a prostate biopsy and had a typical scheduled follow-up visit to go over the results and talk about next steps. The patient missed the appointment and called, but he wanted to get the results over the phone, which is something that I've never been a fan of. And despite my resistance, he persisted. And unfortunately, his biopsy was positive, and that was the information that I shared. And very shortly after I shared that information, he hung up somewhat abruptly. Then his wife called about 5 minutes later and said that he was hysterical And how could I give him that kind of information on the phone? And I did not have a good defense, because one thing that my chairman in training told me a long time ago is, don't let a patient convince you to do something that you don't think is in the patient's best interest. And that was exactly what I did when I gave him the information over the phone. So that was my bad, my mistake. But I mentioned that just because of a real concern about the effectiveness of televisits, audio only, and even that include a video component. Are they really adequate to drive the same kind of shared decision-making that's important to have with something like prostate cancer, that has multiple implications with everything from active surveillance to very aggressive interventions? And I think that's an unanswered question. I do have concern about the way in which providers may not appreciate the cultural underpinnings that you need to be aware of to have effective communication, especially with someone who's not from your culture. I do have concerns about the way in which you can't appreciate nonverbal cues that might not be as detectable doing a virtual visit. And I'm just not sure about the impact that that's going to have on decreasing disparity, because there's definitely a risk that it can make disparity worse if you have a screen that creates an additional hurdle with the way in which you're trying to communicate with the patient. So, but by the same token, I do see that there can be opportunity. I see the potential that you could use a digital interface to try to bring in better resources to have shared decision-making conversation. You may be able to link in decision aids, decision guides, decision tools to that virtual visit. You may be able to even link with an additional person to be a cultural translator that wouldn't have to physically be on site in your office. And the same way, you could possibly collaborate with a decision coach that could also participate. So at the same time that there's challenges, there's also opportunities. I think in its current state, I'm more concerned about the risk related to multiple things that have already been discussed, including structural and systemic issues with access, broadband access, the type of digital tool that a patient may have to share in that virtual visit. But as I mentioned, I think because virtual visits are here to stay, I think we need to think about them from an innovative approach to how to make them better so they can become some of the answers, some of the resolution for driving better health equity. And that is, those are the comments I'm going to make for now. There was a whole lot that has already been shared that I wish I had more time to help unpack, but thank you.
Thank you. Thank you so much for that great introduction to the panel. And we'll come back to you later, Dr. Waterhouse. And I think I failed to mention that you are now at the Carolinas Cancer Center. So I'd like to go next to our next panelist, Dr. Jacques Carter. Dr. Carter is an internist in Boston and is professor of medicine at Harvard University. So Dr. Carter, welcome. And please go ahead with your introductory comments to this panel, please.
Thank you very much, Dr. Mitchell, and greetings to all. Dr. Whitman, I thoroughly enjoyed your presentation. I thought it was chock full of a lot of important data that I'll be using with my patients down the line. I think that as a clinician, I'm probably one of the ones on the fence about telehealth. And I think that, and I wondered as I heard the presentation from Dr. Crawford about the people who he surveyed who are on the fence about this. I wonder if some of that middle of the ground sort of sense of where they were came from the doctors. How much of this came from actually from the clinicians who may have poo-pooed some of the issues around telehealth, and that it's not the same as being there. I think that for what I do, which is basically a lot of counseling and education, I'm not a urologist. I don't operate. I'm not an oncologist who uses the medicines to treat. So what I do a lot is counseling and offering advice about clinical trials and complications of treatment and long-term side effects of treatment and on and on and on. And I think that much of that, to be honest, can be done with good telehealth. I mean, I think that if the patient base is agreeable with doing that, I think a lot of that can be done. That being said, I'm still a bit leery of not having that direct contact with my patients. And I actually like sort of sitting down and having discussions with them, with family members. But as Dr. Waterhouse just said, there are ways to sort of tie in other people. And if that can be done, in a satisfactory way, maybe I'd have more teleconferences with family members and the patient, and it would be a lot more satisfactory. But I still have, some issues about sort of doing it all in a telehealth way. But I do understand that there's some benefit to it. I do understand that it allows certain people to have visits that they may not be able to have otherwise. And therefore, I'm not a big time negative for telehealth. I just still have some questions about it. And I'm hoping that as time goes on, I'll answer my own questions and become either a proponent of this or somebody who's against it. I understand that it's here to stay. In my practice at the medical center, we are now mandated to have telehealth built into the schedule. So even as things have lifted up from the pandemic and we're starting to see more people in person, every clinician has to have a percentage of their time for telehealth carved into the schedule. And that's a sense of the importance of that. Also a sense that the institutions are being reimbursed for some of the telehealth. Early on, there were issues around how much you were going to get paid for that, and that they were losing money because of telehealth. Some of those things were fixed. Now, whether or not those are just pandemic era kinds of fixes that will disappear in a year or two when the pandemic is over or not is up in the air. But I think that there is a lot to be said about the benefits of telehealth, but a lot to be said about some of the questions about its effectiveness and whether or not it will do the job. And the question about whether it will decrease disparities is still up in the air, because if the African Americans don't go along with it, then it does not the case at all and does nothing for the disparities. And that means that we need to have more in-person visits for those people who don't buy into telehealth. So that's sort of from a primary care standpoint of counseling patients. I still prefer in person, but I understand the benefits of telehealth, and I have made use of it over the past 18 months, and I think it's a very important component of providing quality health care.
Thank you so much, Dr. Carter. And we'll come back to you later as all of the other panelists have spoken. So I would like to ask if Dr. Coleman has joined the session yet. Can our manager tell me? I assume she is not here yet. I was told earlier that she had some connectivity problems. So I would now like to move forward with our patient survivors comments, and then we'll open the panel. First is Mr. Derek Butts. Mr. Butts, would you like to give us a few minutes on your perspective as a cancer survivor, please?
Yes, thank you, Dr. Mitchell, and thank you for the FIN Network for inviting me to this well-needed and well thought out and discussed seminar of information. It's very useful. I am a 5-year prostate cancer survivor. I come from 3 generations of prostate cancer. However, the last 2 generations, my father and myself have actually work to deal with it. As part of that, also started a nonprofit, Prostate Cancer Awareness Alliance. We're trying to help work with these disparities in the community in the DMV area. And in looking at this and going back to Dr. Waterhouse's comment earlier about disseminating information, that's something we try to help understand through the educational process, as Dr. Crawford mentioned earlier. It's really important to educate so people understand exactly what they're getting into. When I was diagnosed with prostate cancer back in 2016, I did get that call, and the call was, Mr. We're starting to inform you have prostate cancer. But at the same time, when they asked the question, we'd like for you to come in for a consultation to discuss options, my immediate answer was no. And I said that because I knew exactly what I wanted to do. And that's part of the understanding process. So that particular connection was something they need to work with. And that's something that I was prepared to work with as well. As that came across from a telephone conversation, I was prepared for that answer, the decision I got back from my biopsy, and be able to move with it. So as I move fast forward and we get into COVID, we look at the disparities as far as now, you can't go in to get that information. You can still need to go in and get your lab work and blood work done, as mentioned earlier by Dr. Whitman. But at the same time, you still need to have that comfort level. And one of the things we've been trying to do with the Prostate Cancer Awareness Alliance is, from our perspective as a prostate cancer survivor, is help other men become comfortable. The question we ask them is, if you were told you would be at high risk of getting cancer sometime in your life, how would you live your life? How would you prepare for it? Where would you go to seek answers? How would you, who would you talk to get information that you'd be comfortable? And what options would you seek to understand what the treatments would be? And basically understanding the importance of prostate health in general. And I think all the things that were discussed today, when you talk about that understanding of education, it's very important. Now, fast forward to the telehealth component. In my earlier life, I was actually an enterprise solutions architect, and we dealt with disparities in the community in the DC area. And this did under education, work with Howard University quite a bit in early 2000 of how to bridge that gap between disparities of education. Bandwidth was the biggest issue. And it's no different here when you're looking at the disparities of looking at how do you reach those individuals, those patients, and working with understanding their health, understanding their care. Bandwidth also goes back to those issues. When we look at the way we can bridge that gap, one of the things we did was actually partner with some of those bandwidth providers, the Verizons, the AT&Ts, the T-Mobiles, to really help them work with reaching those underserved communities. So when we look at the telehealth aspect of it, we look at what are you comfortable with doing? We realize the population which we're trying to serve, you have those older people over 65 that are not familiar or comfortable with computers, their smartphones or interfaces. And we try to help them with the education process, as Finn is doing as well, and working with Finn to say these are information sources. Finn is a great site to go to get information, understand it. So when you do have that televisit with your doctor, know what questions to ask, know to understand what treatment options are available. So it's part of that understanding and learning knowledge, but you have to establish that comfort first. And it's kind of hard to do the comfort level of that working with the patients and those people who are diagnosed with prostate cancer if you haven't developed that relationship beforehand. You can only do so much over Zoom or Microsoft Teams when it comes to virtual conversation. And what we're really trying to do is help bridge that gap in understanding the information that needs to be discussed with your doctor, but also understanding, what's the best means to disseminate to you. You've got the emails, you've got the video, you've got the phone calls. But at the same time, if that individual or the other person on the end of the phone is not comfortable with what you have to say or the information you're trying to disseminate, it's really not going to penetrate and sink into them. So we really want them to be comfortable with that. We really try to help really, look at realistic expectations, realistically build that trust. If you haven't developed that trust before telemedicine, it's going to be hard to develop that trust afterwards. We also look at setting realistic expectations. When you have these, the doctors and procedures working, reaching out, we were really looking to make that worthwhile so it makes sense when information is being shared. And my last comment is just really looking at how we can better work with those individuals to understand, understand what they're really going through. So we ask them to adopt a chess mindset, be proactive in your prostate health, understand what your options may be if you should be diagnosed with prostate cancer, and know where to go get treatments in the long run.
And thank you so much, Mr. Butts. We'll come back to you for additional comments with our panel. Thank you.
Thank you.
Our next panelist, Mr. Azel Martin. Mr. Martin, if you would like to take a few minutes and give your expertise on this panel, please.
Yes, thank you for inviting me to participate in this panel to discuss the impact of telemedicine during COVID-19 and prostate cancer care and racial disparity. Telemedicine will never replace traditional medicine in the standard of care one is accustomed to. However, it will eventually become part of the system as an effective tool. During COVID, it established itself as a means to make contact with patients who were in need of constant follow-up or live in rural areas. Telemedicine is also convenient and cost-effective and can generate new financial streams as your client base builds. Telemedicine can adversely affect African American men and delay the tracking of PSA and early detection of prostate cancer. This population would be impacted the most due to delay of testing. The cancer can become more aggressive. Telemedicine is not a useful medium in the treatment of prostate cancer. This is my thoughts. We know this cancer is the second leading cause of death in African American men. During COVID-19 lockdown, only 1% of Black men underwent prostatectomy, while white men were 26%. Prior to the pandemic, there was not a statistical difference. The rate was 16% of African American men and 18% white men who had the procedure. Telemedicine would delay the screening of Black men who are already in fear of this outcome. They would prefer to talk via phone or computer rather than the necessary hands-on approach necessary for prostate cancer detection. So as everyone says, knowledge is the best power. I think that if a person or African American is having prostate cancer problems, I think they need to sit down and talk directly with a doctor and get a good feel from that doctor about what can happen or what type of medical issues they can bring forth to this patient to relieve the prostate cancer issue. Those are my thoughts. Thank you.
Thank you so much, Mr. Martin. Those are really intuitive comments. Thank you. So I would like to now ask Mr. Barnes, if you can give us just a few minutes on your contributions to this panel, and then we'll bring the whole panel back together. Mr. Barnes.
Yes, well, thank you, first of all, for inviting me to participate on this panel. As my initial thoughts are, having been a survivor since 1993, of course, I've seen many changes. I first was diagnosed and had a radical prostatectomy in 1993 under Dr. John Moll at UNC hospitals, and I transitioned since that time to the Duke care team, Dr. Andrew Armstrong and Dr. John Ragsdale. Andrew Armstrong has been
I think he's a friend of Mr. Farrington. He introduced me to several trials, which I believe have been very beneficial in my survival. I am in favor of telemedicine, as I believe the access for, in particular, minority patients would not suffer due to situations such as COVID. I believe the access will be still there, and the discussion with the patient is very important to patients is still available, so they can make good decisions along with the care team's input. I am so pleased to understand the actions of Mr. Farrington and Finn, and would like to see those types of inputs and influence increase, and so that the accessibility to healthcare remains and increases for minority patients.
And thank you so much for those comments, Mr. Barnes. That is so true. And congratulations to you for being a survivor for so many years. Thank you.
Thank you very much.
At this time, I would like to invite all of the panelists to unmute themselves. And we're going to have some questions and answers, some from the audience. So I would like to first thank Dr. Waterhouse for his intuitive history with a patient and a telephone information. Certainly years ago, I was also taught, excuse me, not to give bad information over the telephone. However, what was necessary when you had information where you needed to see the patient earlier than their scheduled visit, somehow you needed to convey information to the patient that we need to see you sooner than was planned because of some new test results or more information. And therefore, we had to devise methods of getting that patient back in without telling them bad news on telephone. And therefore, we had to learn how to give information to patients, get back in earlier without giving information that may compromise their immediate state. So thank you for bringing up that. And that has been actually one advantage of telemedicine, that we're used to talking to patients either by telemedicine or over the telephone. So my question to our patient group, and Mr. Martin, you stated the information so eloquently. And I'd like to ask you again, what do you think the real advantage of telemedicine is? And is this going to be a permanent part of medicine, do you think? And how do patients think that we are doing with telemedicine? Can you comment again?
I do think I do think that this is something that will happen. I'm not sure at this point how effective it will be, but it is effective for people to do new prescriptions or refill prescriptions in that manner, or to contact their doctors if they have a surgery procedure. They may be able to look at the surgery online or by phone, by pictures, things like that. I think that would be effective. I do think that in prostate cancer, I think you definitely need to have your blood tests. and you definitely may need to have a rectal exam. So I think these things are very important to the African American community because, as we said, our people die 2 times more than whites. And your third question was?
The third question, how do you think we are moving forward? I think you've answered it, but how do you think this will be incorporated into the future of medicine?
Well, I think it will. Some of the parts of this telemedicine I'm not agreeable with. My primary care doctor said that he wanted to have a telemedicine with me. And I said, you're not taking my temperature. I'm not getting a blood test. I'm not getting anything but conversation. And I asked him, am I going to have to pay a copay? And he said, yes. And I said, I feel like I'm not getting 100% of why I should be making a copay when I'm not really visiting you. So you can really look at me, you know what I mean? If I have a bruise or if I have something that may be happening to me or how I'm feeling about a medication, you know what I mean? I didn't feel as though I was getting a complete examination to that point until times permitted me to sit down with him, you know, to have a full examination.
Mm-hmm.
But I do think in the future, this is something that will happen simply because we have to change with the times. And I think this is something that it will be done, and I think they will affect a lot better to make patients feel a lot more at ease with the telemedicine.
Yes, thank you so much.
Yeah.
And I'm going to ask Dr. Carter to comment now. There are devices that we can use such that we can collect an EKG through telemedicine and through the our smart watches. We can listen to the heart and a number of other components of the physical examination. So I'll ask you as the internist, Dr. Carter, what are your thoughts about the smart devices for telemedicine and actually augmenting the components of the physical examination? Tell us a little bit about that.
I think those devices are great, to be frankly honest. And probably 50% of my patients use those. And they come in and they tell me what their vital signs are. And they come in and they tell me that they're concerned about their pulse, which is too high, and on and on and on. So I think that those are very important components of healthcare. I'm just saying that we're looking at the future. And as we move forward, there'll be a lot of devices, and we have to sort of, we as Americans, I guess, have to sort of get used to some of these things that some people might find intrusive. There are concerns about how much of your data gets picked up in other places. My wife and I bought a mattress recently, and there's a device in there that told me how you could sleep. If you plugged it into your bed, it could tell you a lot of information. Some of that stuff I can do without, but I think that it's important to be able to look at vital signs, look at heart rates and all that. But I still think that when it comes to cancer, I think there's a lot of hand-holding when it comes to cancer evaluation, diagnosis, and treatment. And I think a lot of that does not bear well with, telecommunications, telehealth. I've been in the same situation out of the Waterhouse where somebody pushes to get information, and you try to give them an appointment, and they say no. Well, then they get a little leery. They say, well, maybe there's something bad going on, but they still don't want to come in. They want you to talk to them on the telephone, and that's very, very tough to do. And I've been sort of exactly where you are. I had a patient once who had rising PSAs for 9 years, refused a consultation with urology, refused anything. So finally, his numbers got so bad and he had symptoms that he came in with his wife, because his wife said to him, doesn't your doctor know anything about prostate cancer? So I had to say in front of her then, did you tell your wife that we've been doing this for 10 years? and he sheepishly said yes. So I think that there's a lot of stuff that goes on in the exam room, in the personal consultation that as a clinician I'd hate to give up. But I do understand the other piece, that for some people, doing some telehealth, sort of making some devices available that can take temps and do pulses and all that is going to be the wave of the future. And I'm not standing in the way of that. I just think that for me, I'd like to see it move a little bit slower than it's moving right now.
And that's the same that I find. I have to keep up with all of the devices and new things. But I did have the opportunity recently with a patient who had a history of abnormal heartbeats and had a smartwatch. So I was able to hear the the heart, and I asked him to press a button to give me an EKG.
Mm-hmm.
So I got the EKG, and I was able then to get his cardiologist on the phone and send the cardiologist the EKG.
Mm-hmm.
And I said, you know, so consultation right there with the patient still on my telemedicine visit. And I got his cardiologist interpretation of the EKG, and we could give him the appropriate advice. So they are extremely helpful, but you're right, you got to learn how to use them. And fortunate for me, I'm around medical students and residents and fellows frequently, and I tell them, the young kids teach me how to use these devices. But we've got to learn. It takes a whole learning experience to get to know how to effectively utilize all of the processes that that we have. So Dr. Waterhouse, do you want to add comments there?
Yeah, I really love the way that the technology advances are proceeding. But I did have some additional comments that actually add a layer of complexity to this discussion, and that is that nationwide, over 90% of the virtual visits that took place were performed by either behavioral health providers or primary care providers. So the way in which that adoption of virtual visits with specialists has not been at quite the same pace, quite the same level. And I think it's a very important distinction, because primary care providers have a deeper relationship, have a greater degree of rapport in general, not absolute with every single patient, but in general, they do. For example, if you're a urologist and you're seeing a patient who has an elevated PSA as a consult from a primary care provider, you may have only seen that patient once or twice before you make a diagnosis. You don't have that same depth of relationship. And then you're going to go from that to not being able to reach across that screen and actually hold that patient's hand when you give them that type of information. I think it's a big challenge. So in summary, I'm just trying to make the point that in some ways the challenge is even greater for specialists, and that impacts the prostate cancer area because specialists get involved in their care. Specialists are a big part of that: urologists, medical oncologists, radiation oncologists, et cetera. And so that only magnifies the potential drawback or negative, the potential adverse impact of virtual and televisits on prostate cancer and prostate cancer disparities. So I just want to make that brief comment, but I do love what primary care providers are doing, and they're using these digital tools. It's wonderful. It doesn't apply as much to a urologist, but I do have some concerns about the impact as a specialist who doesn't have the same degree of rapport in general that primary care providers do with patients. Thanks.
Ruth, Edith, sorry. I wanted to make one comment, and just to dovetail on that. Telemedicine has always been here. And we just now were forced to take advantage of telemedicine. I don't see it as care as a binary. Telemedicine, no telemedicine, in-person visit only, or telemedicine visit. I think it has to be a hybrid solution. And that way, patients are stratified according to their health or their diagnosis. But the reason why I bring it up is because in the Boston area, the Dana-Farber Cancer Institute had clinical trials. And what I saw in their program is they had telemedicine, but then they would also incorporate nurse practitioners or nurses aides or people going out to see the patients to do kind of a hands-on checkup. So I just wanted to say that we may have to be extremely creative about maintaining that personal touch, but these are kind of solutions that we're looking for. And a lot of these solutions are going to be coming because no matter what, I think that from the standpoint of clinical trials and telemedicine and clinical trials, and as I said before, I was just privy to what was going on at the Dana-Farber, and that there was a clear increase in the utilization of telemedicine, but it's still, they had the ability to maintain the common touch, having the ability of someone, not the primary care doc, but a nurse practitioner or some healthcare professional to make a visit. So there may need to be hybrid with the stratification of the patient population.
Can I add to this discussion?
Go ahead.
Go ahead, Dr. Whitman.
Okay, so I want to speak from the point of view of, behavioral health person who's also a specialist. I had a very interesting experience having transitioned fully to telehealth visits in doing sexual health assessments in prostate cancer survivorship. We, from the start of the survivorship program, invited partners to participate in these sessions, and we had about 80% attendance, and it really contributed to being able to develop care that was very much both patient and couple focused, and patients really appreciated it. And most of my research is on that as well. When telehealth came, I found that over time, partners stopped showing up for the visits. I think that when men were coming for these appointments, they were a little bit nervous, so the partners came perhaps for support. But when the patient was sitting at home at the living room table or on the couch, the partner didn't necessarily feel like that they had to provide so much support, and it really limited what the assessment and planning could do for patient care. So I feel as if, from that experience, so this is just clinical experience, not empirical, I think we really need to study what is appropriate for telehealth versus what is not. It's both stratifying the type of visit, the type of patient, the type of condition, but it's also the type of intervention that lends itself better to this kind of a approach than others, because you really lose, number one, you lose information when everybody's not in the room. And then you also limited in how you can help people. And having seen how much men and couples really want help with this type of problem after prostate cancer treatment, it was a little bit disheartening. So I know that, in the future, I'm going to want to study this. I'm going to want to find out how to best use telehealth to both be, to both expand and improve care, but also to not overuse it.
If I may add to that also, I think Dr.
I wanted to ask Dr. Whitman if I could, what differences, or have you noticed any differences regarding Black patients or other racial or ethnic minorities? Are there any differences, or do we have a one shoe fits all?
I think it's relatively speaking, one shoe fits all. We have at the University of Michigan, our proportion of African-American patients is fairly small. It's a kind of a lily white environment. But we do have some Black men who come with their partners, and when they come with their partners, it's very similar to everybody else, and the dropout rate is very similar to everybody else. I would say it may just be that African American men do more on the phone than video visits in general. And when people are on the phone, it's harder to engage the partner in general as well.
Thank you.
Sure.
Mr. Butts, I'm sorry that I interrupted you there,
Not a
but I
problem.
wanted to know from Dr. Whitman's research, are there differences in how individuals interact, whether we have to do something different for disparities and to make sure that we're not developing a system where we are, and I say we, meaning African Americans, are again left out?
Yes, I fully agree. And I think it also goes back to what you said earlier with the educational process and setting expectations. When COVID hit, we were all kind of thrown into doing telemedicine without really telling people what they were getting for it. And as Mr. Martin mentioned earlier, he was asking the question, but a lot of people don't ask, what am I really getting out of this? And then they don't get the information that they need as part of that process to really get the full coverage to understand what they're really exposed to or what they really have. And I think when you look at that, it's really important to go back and really tell people what they're going to get. And it takes time. And I know, as Dr. Whitman mentioned earlier, the spousal thing, I also mentioned with Dr. Waterhouse, that's also very, very important, whether you're in person or whether you're telemedicine visit, because they are the ones that are going to be the ones to help console that individual, help them get through that mental aspect, the anxiety, the stress, the depression that they may go through because of the information that's disseminated. So again, setting expectations and knowing to what the outcomes would be, how the spouse should interact and work with that person who's receiving the prostate cancer news, that's important. And I think that's something we can do better through telemedicine and telehealth as far as setting that expectations.
That is so true. And one of the things that we have done in my practice, and I'm an oncologist, so I'm seeing the patient new with a diagnosis, and then I have to follow up with treatments, is to make sure there is another person that is involved in that patient's care, and that you know who they are and how you can contact them, and make sure that they are a part of the discussion. And of course, all of this with the patient's approval.
Mhm.
And I actually asked the patients early on, who is the next of kin? And if there was ever an emergency where I had to make a decision and you are not able or capable because of your medical care, who is that next person that I need to contact? And I ask that maybe not always on the first visit, but usually on the first visit, so that that I know. And Dr. Waterhouse, I loved your description of the entity that you described. But early on in my career, I was taking care of a patient and a woman was with him. And I guess I didn't ask, who are you and what is the relationship? But later, when the patient needed some critical things, another woman showed up and said, I'm Mrs. XXX. And I was floored because I had to come up very quickly and the patient was sick, with an answer to figure out who actually was, the right person to make that decision. So now that taught me. And on my first consultation with a cancer patient, I will ask, who is your next of kin? And if I needed to have a critical decision, who would that person be? And you find out that many times it's not the spouse, it might be a child or other individual. Most frequently, it's a child who the individual will want to be informed, make the decision, and help the spouse in the decision-making process. So other comments? I'll ask Dr. Carter about that. Dr. Carter, you see a lot of individuals on follow-up after cancer treatment and in discussing side effects, long-term issues, surveillance and follow-up of that cancer, but also individuals having one cancer are at risk for, or at a higher risk for a second or third malignancy. And I will ask Dr. Carter, how do we incorporate that into overall care, since the list might not have that, the specialist or subspecialist might not have all of the information to recommend surveillance and screening for other cancers. Dr. Carter, are you still with us?
Absolutely.
Okay.
So what I do actually is that when I'm screening guys for men for prostate cancer, and the PSA is rising, and I get them out to see the urologist, I make sure, one, that they see that they get triple consults on everybody. Even if they say, I know what I want, I make them do it anyway. I have them see the urologist, have them see the radiation therapist and a medical oncologist, and I have them come back to me because I want to know what they think. And oftentimes they'll say, well, what should I do, doc? And I try to avoid that as much as I can by using the value issue. Well, your values may be different. I may want something that you might not want. I don't want to answer that, but I try to get them to make a decision about what they want to do. But when they go to treatment, I make sure that they have scheduled appointments to come back. And I actually have done some work with the Department of Public Health here in the state on survivorship programs. So I've done a few videos just saying, this is why I want my people to come back. There may be some issues that they'll discuss with me that they might not discuss with you, Dr. Mitchell, or Dr. Waterhouse. And I want them to come back and talk to me about those kind of things. There may be long-term side effects that, like you say, the urologist may not be familiar with, or they don't see the person after a couple of years. They're not going back for routine follow-up, and somebody has to pick up on those pieces. So I just make sure they come back, and as a rule, they all come back.
Mm-hmm. Very good. Now, this question I will open up to everybody. And that is, we are doing a lot of genomics and genetics in patients with cancer. And I find that telemedicine is aiding that. So with precision medicine in cancer now, precision medicine in prostate cancer, what are your thoughts about telemedicine and getting information, getting to know about precision medicine and genomics, or its introduction in your processes and your healthcare delivery? So I open this up to survivors, physicians, everybody. And Dr. Whitman, I didn't leave you out as the psychotherapist. Anybody want to start?
I'll go ahead and start. So one of the things coming from 3 generations of prostate cancer, I was actually taken up as a case by NIH as a prostate cancer tissue patient for the study of my cancer. And reason being is because not only did my grandfather have it, but also my father, my uncle, and I got it. So it's most likely one of my sons may get it also. So this was intriguing to them to understand the genetic process and makeup of how it was passed or how fast one would get it. I was started tracking my prostate at 38. I was not diagnosed to 53. So just looking at that also, and also the effects I had, I was asymptomatic. I had zero stimulation or zero things that said, you've got prostate cancer. It was the rise in my PSA that let me know there was an issue. So I think understanding the family history is important. I think knowing the fact that you may be predisposed to it is important. I think just sharing that information and how others may be predisposed to it also, because I think it helps those men who come along afterwards understand what they may be possibly exposed to down the road. I think communicating that will help them understand it's a journey and it's not something that it's not going to go away. And as they say, if you live long enough, you're most likely going to get it but may not die from it. But our thing is really help men understand before they get it, what to do with it.
Mhm. Understanding. And now we have information that we have produced at Jefferson, and not only Jefferson, but other institutions too, is that there may be a relationship of the gene, of one of the genes of BRCA that we usually associate with breast cancer, but now we're testing our prostate cancer patients and finding that there is a relationship between BRCA1 or usually BRCA2 and prostate cancer, and therefore doing more genomics. So Dr. Waterhouse, have you incorporated that into your practice, or can you speak on that topic?
I hate to be a naysayer, but I do have to make a comment. And that is that I think the more scientifically complex an issue is, the more challenging it is to talk about it in a virtual format. And that might be reflective of my own insufficiencies, but that's just what I find. I really support what's happening with precision medicine. I think it is a valuable tool for us to better prognosticate prostate cancer. And there's no question from the science that's already coming in about BRCA. I think it is going to be an important tool along with other types of biomarkers. But talking with a patient virtually, I see as making that conversation more difficult. And I'm not sure how I can tell you why, but it just seems to be as from a scientific perspective, as the issue is a little bit more complex. Not everybody really understands genes and how mutations in DNA affect the way in which prostate cancer may behave, or any cancer may behave. So that's just my little 2 cents.
Oh, Dr. Mitchell, can I dovetail on that?
Absolutely, Dr. Crawford. Go ahead.
So this is right here. That's exactly what we wanted to hear to a certain extent. And if you look at some of the programs that Finn has created, we have a whole segment when we talk about introducing the concept of understanding your genes, gene therapy, understanding the importance of your genetic makeup. And so we recognize that the physician can't do them by itself. That's why on our end, again, the tide raises all boats. So what we try to do is, again, give the patient, the survivor or prostate cancer patient, a little bit of information about genetics. Why is it so important? The BRCA1 gene, its relationship with breast cancer, but what about the relationship with prostate cancer? Now, if you have that gene, there's a different therapy that you may need. So for a patient to decide on the appropriate treatment, because we're asking the patient to share in the decision-making process, there is a need to educate the patient. And what we try to do is take some of that off of your back and bring that patient in. And then I'm gonna close out is that we have something special coming up, but you will only have to listen to me in session 3.
I have to.
Okay, Dr. Crawford, that's great. And there are people who can assist with it. We actually have clinical trials for patients who have previously been treated for prostate cancer and who may be cancer-free with all of the evidence we have. But that just emphasizes the importance of clinical trials and how we should either have the trust and offer the patient that consultation and assistance, or gain the patient's trust so that we can make sure that we are utilizing for every patient all of the tools in our toolkit for patients, and therefore engage patients in clinical trials. There was a clinical trial survey, Dr. Crawford, right up your alley.
That's right.
On why they didn't participate in clinical trials.
Mhm.
And do you know what the most 80% of the patients said?
They weren't asked.
The doctor didn't ask, or the doctor didn't recommend it. Actually, patients don't necessarily look for you to ask them. They want you to recommend, doctor, what do you think I should do? What do you think is the best? But the doctors didn't ask. And clinical trials on genomics and genetics, and we sometimes do discuss patient genomics or genetics. And we have to explain that to the patient, where a test result may influence screening or screening for other family members, or treatments, as Dr. Carter said, there are some specific treatments that are based on the genomics of the tumor. And I find that telemedicine is really contributing to the patient information and education and recommendation for clinical trials in the area of genetics or genomics.
Dr. Mitchell, I'd like to sort of
Dr.
just,
Carter, go ahead. I'm
just-
sorry. Yes, Dr. Carter, go ahead. I'm looking at 2 or 3 different people on my screen.
just a quick piggyback on what Dr. Waterhouse said. I have to agree that it may be okay to have an initial, ed session with somebody on telehealth, but I think that if you're dealing with genomics, I take out pad and paper and I sit down and I write stuff and I draw things, and I need to sort of have that person there. So I would agree with an initial telehealth session, as long as there was a follow-up in-person session where we can sort of go over the material. So just my 2 cents worth.
Absolutely. And there are sometimes you really need the patient and their support in the office for face-to-face conversation. But I think more and more we're using telemedicine to at least assist with the introduction.
But can I interrupt for 1 second?
Go ahead, Dr. Crawford.
Before, we've always been in some form of telemedicine. And from an educational standpoint, that's what Finn has been doing from an educational standpoint, to raise the level of understanding. So when that patient, whether it's time for me to screen, or it's a type of treatment that I need, or a clinical trial discussion, they have a base understanding of the topic. And so we'll keep, and if you have people, you can refer them to us, and we'll help them bring them up to speed so they can have that discussion.
Absolutely, thank you. There was one thing that was brought up earlier, and that was about broadband.
Yes.
And there is a lot that we cannot do, but just to mention that we do work with the Congress. That's a part of health policy.
Absolutely.
And in working with the Congress, you don't have to be invited, but if you got an opinion, get your local congressman or woman, whether they are white, Black, or whatever, make sure they know who you are, and frequently give them opinions regarding decisions that Congress is dealing with. I believe Mr. Meeks is not on the line now, but I certainly offer to everybody, communicate with your congressman or congresswoman, and let them know what your thoughts are. And believe it, that after you do, they will come to you for information because they know you are a trusted resource. So let's not leave out health policy in this decision-making and make sure that we're contributing what we can. So this has been a tremendous discussion today. Ms. Harrington, thank you for inviting me to monitor the process and be the convener for this session. And I would like to invite you back to give us some last words.
Thank you, Dr. Mitchell. And this has been, I think, a very informative, a very enjoyable session. And Dr. Mitchell, I think this is about the fourth time that I've asked you to participate as a moderator, a presenter in our summit. And, each year when I think about the summit and who we will have participate, your name always comes up first. So, and after today, you've done such a great job with this section. Your name will come up first again next year. So I'm going to ask my audience and all the panel members to give Dr. Mitchell a virtual round of applause for a job well done.
Thank you so much.
Thank you so much. And I also want to thank all of our presenters and all of our panelists for your remarks and your contributions. I think we covered a lot of ground during the session. We all know that telemedicine is here to stay. Based upon everything that I read and I see, it really will probably get more traction going forward. And so the question for us, and as the representative for African-American prostate cancer patients, is where will we land? Will it be an asset for us? Will it help us eliminate or address the disparity, or will we fall further behind? And the purpose of this session was to discuss just that. And I think we got some good information from the session. I think there's work to do. Clearly, we have to do our job. Our job is a patient education and advocacy organization. When you look at the survey that we completed, one of the things that hit me when I first looked at the numbers was that we had about 76% of the respondents who were pleased with their telemedicine care. But when you looked at whether they thought telemedicine would help eliminate the disparity or would increase the disparity, those same people didn't seem to have the confidence in the system that telemedicine will really help eliminate the disparity. So what that tells us is that we have a lot of work to do. We have work to do, Dr. Mitchell, as you mentioned, on the policy issue, and we will address policies in our fourth session at the end of the month. We have work to do there. We have also work to do in working with the patients and educating the patients and working with the providers. We do not want to be left behind. We cannot afford to be left behind. We cannot afford to have telemedicine add another layer of disparity as it relates to prostate cancer. And so our job is to have sessions and discussions like this, and then to find ways to make telemedicine an asset, to have it help eliminate the disparity. If as I said, we're not going to be able to stop it, but we have to be engaged in the game. And so I thank everybody today who presented and on the panel for participating and helping us get engaged in the game. I think we better understand now some of the issues from a number of sides. I really enjoyed the perspective from all of the doctors and all of the patients. Great perspective. And I will say that Finn, we will continue to move forward on this issue of telemedicine and finding strategies and approaches that will really help make telemedicine an asset towards eliminating or reducing the racial disparity. Otherwise, we fall behind. So again, I want to thank all of you for participating today. And I want to thank our audience. We've had a great audience. They've stayed around for a long time. And I thank you so much for tuning in today. I want to invite you to tune in next Wednesday when our session will be on outreach, community outreach, awareness, and education. So we will continue our summit a week from now. And again, thank everyone for being with us today. And with that, I think we end our summit about 3:31, which may be 1 minute beyond what we had targeted. But again, thank you all. And bye-bye.
Thank you.
Goodbye.
Long.